Muscle pain that begins while you are taking a statin creates an uncomfortable dilemma. You may worry that the medicine protecting you from a heart attack or stroke is damaging your muscles. At the same time, you may be afraid to stop something your clinician considered important. The first useful distinction is this: unexplained muscle pain deserves attention, but the presence of pain does not automatically prove that the statin caused it. In a large analysis of double-blind randomized trials, muscle pain or weakness was reported almost as often by people taking a placebo as by people taking a statin. Statins did cause a small increase in mostly mild muscle symptoms, particularly during the first year and with more intensive treatment. However, the researchers concluded that more than 90% of muscle symptom reports among people assigned to statins were not actually caused by the statin. That finding should not be used to dismiss anyone's pain. The pain may be completely real while having another explanation: arthritis, a strained muscle, a new exercise routine, an infection, an underactive thyroid, kidney disease, another medication, or a condition such as polymyalgia rheumatica. The challenge is to identify the most likely cause without unnecessarily abandoning protection against cardiovascular disease. This matters especially after 60 because muscle and joint symptoms become more common, medication lists grow longer, and the consequences of both undertreating cardiovascular risk and overlooking serious muscle injury become more significant. Today, we will separate three situations. First, the common aches that usually deserve a routine but timely conversation. Second, the symptom pattern that makes a statin contribution more plausible. Third, the uncommon warning signs that require immediate medical assessment. We will also examine the medication interaction that is often missed. A person may tolerate the same statin for years, then develop symptoms shortly after starting an antibiotic, antifungal medicine, heart medicine, or another treatment that raises the amount of statin in the bloodstream. 1. What common muscle symptoms usually feel like? The most frequently reported statin-associated muscle symptom is myalgia. This means aching, soreness, tenderness, cramping, or a heavy feeling in the muscles, usually without major muscle destruction. A pattern more suggestive of a statin contribution is new pain or weakness affecting both sides of the body, particularly the larger muscles around the thighs, hips, buttocks, shoulders, or upper arms. It may feel difficult to rise from a low chair, climb stairs, carry groceries, lift the arms to a shelf, or complete a walk that previously felt manageable. The 2026 American Cardiovascular Guideline notes that a statin-related explanation is more likely when new symptoms are bilateral, symmetrical, and located in the muscles close to the trunk. The timing also matters. Symptoms often appear within weeks of starting treatment or increasing the dose and may return if the same treatment is later restarted under medical supervision. But real life is not always that tidy. One-sided shoulder pain after gardening is more suggestive of a local injury than a whole-body medication effect. Knee pain centered inside the joint may be caused by arthritis. Calf discomfort that appears predictably while walking and improves with rest could represent a circulation problem. Burning, tingling, or electric pain may point toward a nerve problem. These distinctions are not reliable enough for self-diagnosis, but they can make your appointment far more productive. Before contacting your clinician, write down where the pain occurs. Is it in the muscle, the joint, or both? Is it on one side or both? Does pressing the area make it tender? Is the main problem pain, cramping, or true weakness? True weakness means the muscle can no longer perform a task it previously could. It is different from avoiding a movement because it hurts. Also record when the symptoms started in relation to your statin. Include the medication's exact name, dose, and any recent dose change. "I take a cholesterol tablet" is not enough because different statins use different metabolic pathways and have different interaction profiles. The evidence is reassuring on one point. Mild muscle symptoms are far more common than dangerous muscle injury. But reassurance should lead to a careful assessment, not to ignoring a new limitation in movement or strength. When muscle symptoms become urgent. The most serious condition associated with muscle breakdown is rhabdomyolysis. It is uncommon, but it can release muscle cell contents into the bloodstream and injure the kidneys. In severe cases, it may also disturb the body's electrolytes and affect the heart. Seek immediate medical assessment for muscle pain or weakness that is severe, rapidly worsening, or accompanied by dark brown, tea-colored, or cola-colored urine. Feeling profoundly weak or unable to perform ordinary tasks can also be a warning sign. The Centers for Disease Control and Prevention identifies unexpectedly severe muscle pain, dark urine, and unusual weakness or fatigue as key symptoms requiring immediate medical attention. Do not wait for every warning sign to appear. Dark urine is important when present, but its absence does not guarantee that the muscles and kidneys are safe. Other concerning features include significantly reduced urination, severe swelling, fever, vomiting, confusion, fainting, or marked weakness, chest pain, difficulty breathing, facial drooping, one-sided weakness, or difficulty speaking should be treated as emergencies for reasons that may be completely unrelated to the statin. When seeking urgent care, tell the medical team the exact statin, the dose, when you last took it, and every other medicine or supplement you use. Mention any recent infection, fall, surgery, strenuous activity, heat exposure, dehydration, or medication change. A blood test for creatine kinase, commonly abbreviated as CK, can help identify muscle damage. Kidney function, urine findings, and electrolytes may also need evaluation. Symptoms alone cannot confirm rhabdomyolysis, and a urine test by itself is not considered sufficient to rule it in or out. There is also an extremely rare autoimmune muscle disorder associated with statin exposure. Unlike ordinary statin-attributed symptoms, it may produce persistent weakness and markedly elevated CK that do not resolve as expected. It requires specialist assessment rather than repeated unsupervised medication changes. The 2026 guideline describes this immune-mediated necrotizing myopathy as very rare but clinically important. These urgent conditions are not the typical experience of someone taking a statin. They are discussed because knowing the difference allows ordinary soreness to be handled calmly, while serious symptoms receive attention without delay. Timing can reveal more than pain. Severity, pain, intensity is not the only useful clue. The timeline often tells a more coherent story. Suppose discomfort begins several weeks after a statin is started or increased. It affects both thighs and shoulders. There was no injury or unusual exercise, and the person notices genuine difficulty climbing stairs. That pattern makes medication-related symptoms more plausible. Now consider pain beginning after moving furniture, affecting only the lower back and right shoulder. The person has taken the same statin dose without difficulty for 6 years. That pattern points more strongly toward mechanical strain. Yet there is an important exception. Symptoms that begin after years of apparently trouble-free treatment should not be dismissed. A new illness, reduced kidney function, an untreated thyroid problem, major surgery, a high level of physical exertion, or a newly prescribed interacting medicine may change the risk. The 2026 dyslipidemia guideline lists age 65 or older, kidney or liver disease, hypothyroidism, diabetes, alcohol consumption, vigorous exercise, higher statin doses, certain muscle disorders, and medicines 3 that affect statin metabolism among the factors associated with a greater likelihood of statin-attributed muscle symptoms. A symptom diary can prevent several weeks of guesswork. Record the time of day the pain is worst. Note whether it is linked to walking, lifting, getting out of bed, or taking the medicine. Include recent falls, infections, fevers, changes in exercise, reduced appetite, dehydration, and medication additions. Also record whether the symptoms are improving, stable, or worsening. Do not test the connection by repeatedly stopping and restarting a prescription on your own. An unsupervised experiment may expose you to cardiovascular risk, confuse the timeline, or recreate symptoms without appropriate monitoring. A clinician may use a structured process that includes reviewing other causes, measuring CK when appropriate, and, when it is clinically safe, adjusting treatment and observing whether symptoms resolve or return. That process is sometimes called de-challenge and re-challenge, but it should be guided by a qualified prescriber. The goal is not to prove that the statin is innocent or guilty at the beginning. The goal is to protect the muscles while preserving as much cardiovascular protection as possible. The interaction that can change a previously safe routine. One of the most practical questions to ask is, could another medicine be increasing my statin level? This matters because statins are not interchangeable. Some are broken down through pathways that can be strongly affected by other medicines. For example, simvastatin is particularly vulnerable to medicines that inhibit the CYP3A4 enzyme. Current prescribing information warns that strong inhibitors can substantially increase simvastatin exposure and raise the risk of myopathy and rhabdomyolysis. These include certain antifungal drugs, some antiviral treatments, and antibiotics such as clarithromycin and erythromycin. Atorvastatin can also be affected by medicines that alter CYP3A4 or specific drug transport systems. Its current prescribing information identifies older age, uncontrolled hypothyroidism, kidney impairment, higher doses, and particular drug combinations as risk factors for muscle injury. Other possible interactions involve cyclosporine, gemfibrozil, colchicine, amiodarone, verapamil, diltiazem, amlodipine, and certain antiviral medicines. The seriousness of the interaction depends on which statin is used, its dose, the other medicine, and the person's health. This is not a list for making medication decisions at home. Some combinations are avoided. Some require a lower statin dose. Some can be used with monitoring. Others may lead the clinician to select a different cholesterol-lowering strategy. 4 grapefruit is another example of why broad statements are misleading. Grapefruit does not interact equally with every statin, but large or regular amounts may increase exposure to certain statins, particularly simvastatin. A person should not assume that all fruit is dangerous or that one small serving caused the pain. The exact statin and amount matter. Whenever a new medicine is prescribed, ask the pharmacist to check it against your exact statin and dose. This is especially important for short-term prescriptions from urgent care, dental treatment, infection clinics, or specialists who may not have your full medication list. Include over-the-counter medicines and supplements. Natural does not mean incapable of interacting with prescription treatment. If symptoms begin soon after a new medicine is added, contact a clinician or pharmacist promptly rather than deciding which medicine to remove yourself. What CK testing can and cannot tell you. Many people believe that a normal CK result proves their pain has nothing to do with the statin. That is not correct. CK is an enzyme found inside muscle cells. When substantial muscle injury occurs, more CK can enter the bloodstream. A markedly elevated level, especially with severe weakness or signs of kidney injury, requires urgent evaluation. But ordinary statin-associated myalgia may occur with a normal CK level. The 2026 cardiovascular guideline specifically recognizes myalgia with normal CK as a common form of reported statin-attributed muscle symptoms, while myopathy with objective weakness and elevated CK is much less common. CK results must also be interpreted in context. A recent strenuous workout, fall, injection into a muscle, seizure, or other injury may raise CK. The laboratory's normal range, the person's baseline, symptom severity, kidney function, and whether the level is rising or falling all matter. NICE advises people taking a statin to seek medical advice for unexplained muscle pain, tenderness, or weakness. Its guidance recommends CK measurement when these symptoms occur and encourages clinicians to explore other causes when the result and clinical pattern do not support statin injury. A clinician may also consider thyroid testing, kidney and liver function, medication interactions, and other investigations based on the pattern. Testing everyone for every possible cause is not necessary, but overlooking an underactive thyroid or another treatable condition can lead to the statin being blamed incorrectly. The reverse mistake is also possible. A mildly abnormal result may be dismissed even though the person has progressive weakness or a concerning interaction. The blood test supports the clinical assessment. It does not replace it. 5A useful appointment description might sound like this. I developed aching in both thighs about 3 weeks after my dose was increased. I now need my arms to get out of a chair. I have not changed my exercise, but I started a new antibiotic 5 days before the symptoms became worse. Could we review the interaction and decide whether I need CK and kidney tests? That description is far more actionable than simply saying, "The statin is hurting me." The most misunderstood. Finding about statins and pain. The fact that most muscle symptoms reported during statin therapy are not caused by the statin can sound dismissive. It should not be presented that way. In the large randomized analysis, the difference between statin and placebo groups was small, even though muscle symptoms were common in both groups. This means aches are common in the population taking statins, not that the symptoms are imaginary. Expectations may also influence how symptoms are noticed and attributed. This is sometimes called a nocebo or drucebo effect. If a person has repeatedly heard that statins destroy muscles, an ordinary ache may become alarming and be monitored more intensely. That does not mean the person is pretending. The brain's expectation of harm can influence real symptom perception, just as stress can worsen real pain without creating an imaginary injury. A respectful clinician should acknowledge the discomfort while investigating timing, pattern, risk factors, interactions, and alternative causes. There is another reason not to assume the statin is responsible. Abruptly abandoning cholesterol treatment may leave a person with a high risk of heart attack or ischemic stroke without adequate protection. For someone who has already had a heart attack, stroke, stent procedure, or established artery disease, the consequences of losing effective LDL cholesterol reduction may be especially important. The current guideline emphasizes continuing cardiovascular risk reduction using the maximum tolerated statin strategy and, when necessary, adding evidence-based non-statin treatment. The balanced message is therefore not, ignore the pain because statins are safe. It is also not, any pain means the medicine is poisoning you. The balanced message is, report unexplained symptoms, identify emergencies quickly, assess competing explanations, and work toward a treatment plan the person can tolerate. What a clinician may discuss, instead of abandoning treatment. When symptoms are not an emergency, the next step is usually a shared decision rather than a permanent decision made during one worried evening. 6. The clinician may first review why the statin was prescribed. A person with known cardiovascular disease may have a different level of benefit from cholesterol treatment than someone with a relatively low estimated risk who has never experienced a cardiovascular event. The discussion may then examine whether the pain pattern is compatible with statin-attributed symptoms, whether the dose is higher than necessary, whether an interaction is present, and whether another medical condition needs treatment. Depending on the circumstances, a clinician may consider a supervised change in dose, a different statin, or a less than daily schedule using a suitable long-acting statin. Some people who have symptoms with one statin can tolerate another. The 2026 guideline recommends a systematic approach that may include the maximum tolerated statin dose, an alternate statin or dosing schedule, and evidence-based non-statin medicines when additional LDL reduction is needed. These may include ezetimibe PCSK9 monoclonal antibodies or bempedoic acid, depending on cardiovascular risk, treatment goals, access, and medical history. These medicines are not automatically equivalent, and they have their own benefits, limitations, costs, and possible side effects. The appropriate option cannot be selected from a general video. Supplements are sometimes promoted as guaranteed solutions to statin pain. Evidence for products, such as coenzyme Q10, has not established them as a dependable cure for statin-attributed symptoms. Supplements should not replace an interaction review, appropriate testing, or proven cardiovascular therapy. A better question is not, which supplement should I buy? It is, what is my cardiovascular risk? How likely is the statin to be causing this pattern? And what treatment plan gives me protection I can tolerate? That question shifts the conversation from fear to problem solving. Your practical appointment checklist. Before your appointment, write down the exact name and dose of your statin. Record when it was started and whether the dose recently changed. Describe the pain's location, whether it affects one or both sides, and whether the main problem is soreness, cramping, tenderness, or actual weakness. List every prescription, non-prescription medicine, vitamin, herbal product, and supplement. Add any antibiotic, antifungal medicine, heart medicine, gout treatment, antiviral medicine, or new short-term prescriptions started before the symptoms. Mention recent exercise, heavy physical work, falls, surgery, infection, fever, reduced fluid intake, or heat exposure. 7. Ask whether the symptom pattern fits a statin effect or whether another explanation should be investigated. Ask whether CK, kidney function, thyroid function, or another test is appropriate. Ask what cardiovascular benefit the statin is providing in your particular situation. Finally, ask what professionally supervised alternatives exist if the symptoms are judged likely to be treatment-related. Seek immediate care rather than waiting for a routine appointment if the pain or weakness is severe or rapidly worsening, or if it occurs with dark urine, markedly reduced urination, profound weakness, serious swelling, confusion, or other acute symptoms. For mild or moderate unexplained symptoms, contact your clinician or pharmacist promptly, but do not stop, restart, reduce, or alternate a prescription statin without professional advice. The central distinction is simple. Common muscle aches deserve investigation, but are not automatically caused by a statin. Bilateral pain or weakness in the thighs, hips, shoulders, or upper arms, particularly after starting treatment, increasing the dose, or adding an interacting medicine, makes a statin contribution more plausible. Severe pain, substantial weakness, or dark urine may signal serious muscle breakdown and requires immediate assessment. Most people who need cardiovascular risk reduction can ultimately find a tolerable plan, even when the first statin or dose creates difficulties. The solution may involve correcting another medical problem, removing an interaction, changing the regimen, or using additional cholesterol-lowering treatment under professional guidance. Understanding the difference between common, concerning, and urgent symptoms protects more than your muscles. It helps preserve mobility without giving up protection against heart attack and stroke unnecessarily. For more evidence-first guidance on medication safety, mobility, and independent aging after 60, subscribe to the channel.